Osteomyelitis, arthritis. Usually the child presents with high-grade fever associated with limp and or abnormal gait, reluctance to use the limp, associated with pain that can be localized to the site of inflammation. Local tenderness at bone or joint associated with swelling, erythema, and the limitation of movement either partially or totally. Usually osteomyelitis and arthritis has a hematogenous spread source. This is more common, but sometimes non-hematogenous sources via trauma. Destruction of growth plate can occur in neonates, and septic arthritis, it's not uncommon in neonates and can be complicated by destruction of the growth plates, ending by differential limb length and a limb later on. The onset can be acute within days, can be subacute, or can be chronic within months in case of tuberculosis. Most common organisms implicated in osteomyelitis arthritis are Staph aureus and streptococcal. In sickle cell disease, osteomyelitis is usually related to salmonella infection, pneumococci, and finally Staph aureus. As a workup, full blood count will show leukocytosis with neutrophilia as a bacterial source of infection, high acute phase reactants, ESR and CRP. Blood cultures yield in 40 to 60% of cases, as we talk about hematogenous spread of infection. Then needle aspiration of the periosteal space, in case of osteomyelitis to identify and isolate the organism. Arthrocentesis also to get the joint fluid for workup, microscopy, culture, and identification of the organism. In case of suspicion of tuberculosis, so tuberculin scan testing is required. The characteristic radiology appearing in the plain X-ray appear as periosteal elevation like this, periosteal elevations coinciding with osteomyelitis, but take care, this characteristic picture will appear only after 10 to 14 days of onset, so we don't rely on plain X-ray earlier in the disease. However, technician bone scans can be used as they can give positive results within 1 or 2 days of onset of infection. Also, MRI early in the disease can get positive results in case of osteomyelitis and arthritis. This is bone scan showing here the periosteal elevation, and here the high uptake of the technetium at the site of inflammation, coinciding with the periosteal elevation here. Differential diagnosis of bone pain and osteomyelitis include bone tumors. They are not uncommon in pediatric age group. Leukemia presenting with diffuse bone pains, and bone infarcts associating sickle cell disease. As a treatment, 4 to 6 weeks of IV, a prolonged course of IV antibiotics, which are usually selected to be anti-staph, penicillin as first line options. Based on culture results, we can choose we can follow culture results to choose the most appropriate antibiotic, also following results of bone debridement and blood cultures. Surgery is indicated for debridement, removal of dead or necrotic bone if present, incision drainage in case of septic arthritis to release the intra-articular pressure, longer courses of antibiotics for subacute and chronic cases and for atypical organisms. About septic arthritis, which is most common in children less than 3 years age, can be monoarticular. In neonates can be multi-articular due to hematogenous spread most commonly. Most common organism is the Staph aureus, group A streptococci, tuberculosis, Neisseria, meningitis, and gonorrhea, and brucellosis also can present with septic arthritis. Presentation with high-grade fever, swollen joints with and painful, with tenderness, with erythema, limitation of movements, very important. A newborn can present with crying when changing nappy due to inflammation or infection in the hip joints. So our workup would include this is a urgent medical situation. Joint aspiration is needed for gram stain and culture. Blood cultures yield in 50% of cases. CT and MRI, bone scan, these are the initial imaging modalities to diagnose, and it is a surgical emergency to guard against destruction of gross plates and loss of movement, loss of function of the joint, or differential limb lengths later on. So that would present with limping gait for life. So immediate open drainage reduce the intra-articular pressure and avoid aseptic necrosis of the femoral head in case of septic arthritis of the hip joint. Tuberculosis loves the hip joint. Okay, most common site for tuberculosis arthritis would be the hip joint, ending by this complication. Differential diagnosis of arthritis would include viral infections like rubella, mumps, parvovirus, and hepatitis B. They can present with arthritis as viral infection rather than bacterial sources like staph, like strep, like salmonella, TB, and so on. So this can be viral infection. This can be post-infectious or reactive arthritis. Based on the history, Lyme disease caused by Borrelia burgdorferi. Borrelia can cause arthritis. Rheumatic fever, okay, has arthritis as one of the major Jones criteria, with migratory arthritis or affecting the big joints, starting mainly with knees, for example, then hips, elbows, and wrist. Connective tissue disease like systemic lupus and juvenile idiopathic arthritis is a differential diagnosis. Irritable hip. Irritable hip, it's a common presentation in pediatric age group, which is a transient synovitis of the hip joint, occurring mainly in a child who is less than 5 years, with a history of upper respiratory tract infection about 10 days ago, with mild fever and limp, with reluctance to use the limb, associated with normal ESR, normal total leukocytic count, with full range of movement of the affected limb. All what you need is analgesia with bed rest, okay, strict bed rest. Now fever with no focus, okay. We have some medical terms to talk about: systemic inflammatory response syndrome, systemic inflammatory response, okay. Which is characterized by 2 or more of abnormal temperature, abnormal heart rate, respiratory rate, and white blood cells. Okay, so in exposure to infection, on exposure to trauma, major surgery, burn, or pancreatitis. So any stress condition, the body will respond by systemic inflammatory response that has at least 2 of these. Okay, fever or hypothermia plus tachycardia or bradycardia, tachypnea or bradypnea, and leukocytosis or leukopenia. We say it is sepsis when this inflammatory response is occurring in the context of bacterial infection. When this sepsis is associated with hypoperfusion, hypotension, that will result in organ dysfunction, this is severe sepsis. And when this is persistent, despite adequate fluid resuscitation and adequate inotrope support by dopamine, dopamine, melatonin, or by adequate vasopressor support like adrenaline and noradrenaline infusion, this is called septic shock. So we have a continuum of sepsis, starting with systemic inflammatory response syndrome that is not restricted to an tube infection. It can accompany burn, it can accompany trauma, any stress, okay, to the body. When it's caused by an infection, it's called sepsis. When it is associated with severe hypotension and hypoperfusion ending by organ failure, like pre-renal failure, for example, like hematological failure, myocardial ischemia, whatever organ failure would occur, maybe neurological manifestations. So this is severe sepsis, and when this is not responsive to or refractory to the pressor support by adrenaline and the noradrenaline infusion, and refractory to the inotrope support, so this is septic shock. Organisms that would be implicated in such a situation include most commonly pneumococci, Neisseria meningitis, and Haemophilus influenza type B. After routine vaccination with PCV and with Haemophilus influenza vaccine, incidence lowered much. Rarer organisms which are associated with more disastrous course include Staph aureus, group A streptococci, and Salmonella. In neonatal period, the most common organisms implicated usually are SLE, group B streptococci, GBS, Listeria, and E. coli. In immunocompromised, usually fungi can be implicated. Group gram-negative organisms like Pseudomonas aeruginosa usually found. In a child who has indwelling catheters during the course of PICU admission, for example, so coagulase negative staph should be suspected first, and enterococci. In a child with cystic fibrosis, so pseudomonal infections are prevalent. Sickle cell disease, also salmonella infections are prevalent. Viral infection can be associated with sepsis, okay, and the severe sepsis, especially with herpes viruses, enteroviruses like cocci, and adenovirus. Adenovirus usually, and this is a frequently asked question, adenovirus usually associated with more serious courses of disease. About staphylococcal infection, staph or staphylococci are gram-positive cocci, which are arranged or look like this in the microscope, clustered groups or grape-like clusters. Please remember the microscopic picture of different organisms frequently asked for in the exam. So gram-positive cocci, grape-like clusters under microscope. We have gram-positive and coagulase positive and coagulase negative staphylococci based on presence of the coagulase enzyme. Coagulase positive, they colonize skin and mucous membranes, anterior nares, very important, throat, axilla, perineum, vagina, or rectum. So they are present as commensal, normal commensal in different areas of the body. Coagulase positive. Coagulase negative, staphylococci or staphylococcus epidermidis. Also, it is normal commensal skin flora in everyone, which is most common implicated organism in infections related to foreign body, to central venous lines, to CSF shunts, okay, with the only treatment is removal of this foreign body, like removal of central venous line, for example. The most common organism causing sepsis in preterm and in immune compromised. About MRSA or methicillin-resistant Staph aureus, it is an important cause for nosocomial infections. Also can be related to more severe courses of staphylococcal infection. Can be patient's own organism or can be transmitted by hands of healthcare professionals. So good hygiene and medical practice, very important, most importantly, hand washing. Staphylococci can cause a variety of superficial infections, as it is commensal, normal commensal in skin and mucous membranes, related to foreign body infections, as we have just mentioned. Invasion beyond the skin can occur, resulting in localized suppurative adenitis, for example, suppurative inflammation of lymph node, or can be after this invasion through the skin can end by bacteremia and septicemia. Or can be related to deep-seated hematogenous infection, remember septic arthritis and osteomyelitis. Staph aureus also is related to 3 exotoxin-mediated syndromes. So we have presentation of staph can be asymptomatic nasal carriage, which is very common, can colonize the IV catheters and central venous lines, can get entry to reach the circulation and then spread to various areas of the body, can end by infective endocarditis or by abscesses in different areas of the body, either here subcutaneous or in the muscle or in different organs. Vertebral osteomyelitis also can occur. Septic arthritis, even in the hip joint, can occur. So we have a spectrum of staphylococcal infections. 3 exotoxin-mediated syndromes, including the toxic shock syndrome, staph skin syndrome, and food poisoning. So superficial and deep infections can occur with staph. Superficial like styes, boils, impetigo. This is impetigo, okay, which is characteristic by its yellowish crust, which is a common infection in pediatric age group, caused either by staphylococci or group A streptococci, most commonly. That can be mild, they can be more severe, or even bolus requiring systemic antibiotics. Paronychia, okay, which is inflammation of skin around the nails, around nails, can occur with staphylococcal infection. Also, wound infections, suspect always Staph aureus. Secondary infection of eczema, a very important complication of eczema to gut secondary infection to lesions, most commonly also with staph, with strep, cocci, and finally with herpes simplex. Cellulitis or inflammation of skin that can be serious. Okay, suspect gas infection or group A streptococci or Staph aureus. Lymphadenitis, periorbital cellulitis also can present. Staph aureus uncommonly result in septicemia or pneumonia, but when occur, it usually has a poor prognosis. The most important organism in case of osteomyelitis and septic arthritis. About toxic shock syndrome, Staph aureus can secrete exotoxins, which are secreted by the organism and then pass to the circulation, producing manifestations. Exotoxins include these: toxic shock syndrome, toxin 1. Also, group A streptococci, another organism, can secrete exotoxin called toxic shock syndrome like toxin. Staphylococcal toxic shock focus of infection is usually minor skin abrasion. Through minor skin abrasion, the organism can secrete its exotoxin and then it reaches the circulation to give us this horrible syndrome. Another entry was in the past through the use of tampons. Okay, tampons used by females during the menstrual periods. Okay, as holder of blood. In the past, due to reluctance in the use of tampons resulted in passage of the organism and its exotoxin to circulation, causing many deaths. Streptococcal toxin, on the other hand, requires severe deep-seated focus of infection to cause this syndrome. Toxin acts as a superantigen. This is the pathogenesis. This superantigen result or stimulate immune system, resulting in massive T-cell immune response in what's called the cytokine storm that give us the characteristic manifestations of the syndrome. So the child presenting, having a minor abrasion maybe in the skin, having a deep-seated infection maybe, then he acquire or present as high-grade fever, conjunctivitis, diarrhea, vomiting, confusion, myalgia, all are non-specific, pharyngitis and rash, but the characteristic, we have rapid progression to severe intractable shock that can be fatal within hours. The diagnostic criteria include having high-grade fever with diffuse macular erythroderma. Look at this. Okay, this is the erythroderma associated with this toxic shock syndrome. So diffuse macular erythroderma, okay, with high-grade fever, Desquamation occurs, this is desquamation that occurs 1 or 2 weeks after onset, especially on palms and soles. The most characteristic is hypotension, severe hypotension intractable to copious fluid administration to pressors and to inotropes. Usually there is involvement of 3 or more organs, either gut in the form of severe diarrhea or severe hemorrhage and so on, renal, maybe renal failure, liver failure can occur, CNS manifestations in the form of seizures, maybe hematological failure in the form of DIC. So these are the diagnostic criteria. This is diffuse erythroderma accompanying the release of toxin and the high-grade fever. So it is a clinical diagnosis, but detection of toxin or its antibodies can help. Aggressive supportive treatment in the form of IV fluids and vasopressors, okay, for the severe hypotension plus inotropes are required. IV antibiotics are of paramount importance to be given earlier, very early in the disease would be life-saving. Use the anti-staph antibiotics, be aggressive using linezolid or clindamycin, for example. IVIG also can be used to reverse the actions of the exotoxin. The other or the second syndrome, 4S syndrome or staph scalded skin syndrome. Here we have exfoliative toxins released by staphylococci that result in intraepidermal separation of skin. This intraepidermal separation can appear like this in newborn period with generalized exfoliation. Look at the generalized peeling of skin due to intraepidermal separation with the generalized erythroderma associated with the staphylococcal syndrome. In older children, this can appear as tender eruptions like this with localized bully, followed by peeling later on. Okay, logically dehydration will be present as it is a skin exfoliative disorder. Fluid management is very important with IV antibiotics against staphylococcus is very important. This can be the staphylococcal adenitis, cervical lymph node, resulting in abscess formation. So prevention of staph infection by strict hygiene, very important. Hand washing is the most important. And in case of recurrent skin infections presenting in a child, so decision would be the use of topical anti-staph agents plus chlorhexidine soup and nasal carrier cream in a trial to eradicate the carrier state to guard against recurrent staph infections. Staph is a beta-lactamase producer, so they are penicillin resistant. The anti-staph antibiotic of choice are esfloxacillin or co-amoxiclav, fusidine, gentamicin, clindamycin, rifampicin, vancomycin, teicoplanin, mortargocid, and linezolid. These are anti-staphylococcal antibiotics. Finally, drainage is indicated for suppurative infection. The second organism is Streptococcus or Streptococci. They are gram-positive cocci, which are arranged in chains like that. I remember that I have a question in the exam asking about this. And Streptococci can be beta hemolytic or can be alpha hemolytic. Beta hemolytic includes group A beta hemolytic, okay, or gas, or Streptococcus pyogenes, very, very important, having 100 distinct M protein on their cell wall, okay, resulting in or give us rheumatic fever and glomerulonephritis by cross antigenicity of this M protein with self-antigens producing autoimmune response. So remember, streptopyogenes or group A streptococci or gas arranged appear under microscope arranged in chains. Group P, beta hemolytic streptococci or GBS, most important organism during neonatal period presenting by congenital congenital pneumonia, by neonatal sepsis, by neonatal meningitis, and so on. Alpha hemolytic streptococci. These include Streptococcus viridans, which is normal flora. Mutants can be seen in dental caries, and viridans can be seen in infective endocarditis as most common implicated organism in infective endocarditis, especially in a diseased heart, maybe rheumatic heart. So the others of group A, alpha hemolytic streptococci, we have Streptococcus pneumonia, which are encapsulated, called the pneumococci. Starting with group A, beta hemolytic streptococci or gas or strep pyogenes can be also asymptomatic carriage, up to 50% present in 50% of population have normal streptococci as commensals. Most common organism usually implicated in pharyngitis can produce exotoxins, including streptolysin O, to which we search for the anti-streptolysin O tetra to get evidence for streptococcal infection. Also circulating exotoxins of scarlet fever and toxic shock syndrome are present. So can present with autoimmune phenomena due to its characteristic or distinct M proteins. These autoimmune phenomena include the rheumatic fever, presenting mainly in the heart, post-streptococcal glomerulonephritis, and the pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection or PANDAS. Remember PANDAS, and in a child, especially a girl, presenting with new onset neuropsychiatric manifestations, maybe chorea, for example, as neurological or other abnormal movements, can be present, or psychiatric manifestations, abnormal behavior in a girl which was previously normal, suspect the PANDAS. So we have a spectrum of streptococcal infections, starting with acute pharyngotonsillitis, very common presentation. Most commonly, it is a gas infection or strep pyogenes, usually occur in a child more than 3 years, less common in younger children. Otitis media, sinusitis, peritonsillar abscesses, and cervical adenitis, also a presentation, and vitiligo with Staph aureus or bioderma, cellulitis also. Dark red and duration of skin can be serious. Cellulitis associated with streptococcal infection. Another presentation of streptococcal infection is scarlet fever. Scarlet fever caused by release of erythrogenic toxin associated with pharyngitis. So the presentation of scarlet fever can present with suppurative pharyngitis or tonsillitis like that, and then release of erythrogenic toxin will give us this toxic look of the child associated with characteristic erythema. And the characteristic rash of scarlet fever, that is red generalized rash that have punctate lesions. So give the sandpaper texture. In the face, it is his predilection to affect or to appear in the cheeks like that, and forehead usually affected with the typical circumoral pallor. Like that. This is also appear here the rash in the face. With the characteristic circumoral pallor occurring in association with pharyngitis and streptococcal infection. This is strawberry tongue of scarlet fever also. Streptococcal infection can be invasive, which is more common in infants and young children, maybe after varicella infection as a secondary bacterial infection, after an attack of chickenpox. So again, after infection with the chickenpox, secondary bacterial infection, usually suspect both streptococci and staphylococci. Septic arthritis can occur with streptococci, osteomyelitis, necrotizing fasciitis, that is a medical emergency. This is necrotizing fasciitis. With inflammation here in the subcutaneous and fascia, and associated with the changing skin color. This is a deep-seated infection by streptococci. Pneumonia can occur, septicemia also, toxic shock-like syndrome. Also, the streptococci, as we have mentioned, release its exotoxin that need a more deep infection rather in contrast to staph, which need only minor abrasion. So, skin infection with severe pain at the site of infection and then progress to the horrible syndrome of toxic shock syndrome. As a workup for streptococcal infections, generally, so throat swab and culture is usually done. Rapid antigen detection can be done in clinics for rapid isolation of the organ or rapid detection of the organism with high sensitivity. Blood culture for invasive infection, anti-streptolysin O titer, very important, that can be used for diagnosis. The titers are high for about 6 months after the infection. More than 200 TODS units suggest streptococcal infection. Oral penicillin V for about 10 days is usually of choice for gas pharyngitis. In case of penicillin allergy, so a macrolide or cephalosporin, especially first generation cephalosporin like cefalexin. Superficial infections like cellulitis or adenitis by staph or strep. So in these cases, broad spectrum coverage with co-amoxiclav is appropriate. Necrotizing fasciitis is a medical emergency and require urgent surgical exploration to guard against compartmental syndrome and the loss of the limb.